Hi, everyone, and welcome to this lecture. It is my honor to be welcoming our speaker, Dr. Lara Barbir, and she is going to speak to us about supporting emotional security from perinatal to parenthood, clinical strategies for integration over insight. And I'm going to read a bit about Lara from her SoMeDocs profile, which you can find inside our expert directories. She is a licensed clinical psychologist specializing in trauma, depression, and perinatal mental health. She integrates trauma-informed nervous system-based approaches, including EMDR and interpersonal psychotherapy, to help individuals and families move beyond insight towards sustainable emotional regulation and secure attachment. Dr. Barbir works extensively with high-functioning adults, including aspiring and new parents, with a clinical focus on prevention and early intervention across the perinatal and parenting continuum. She is the author of EMDR for Depression, Overcome the Trauma That Drives Your Symptoms, and the creator of a reparenting course designed to support emotionally secure caregiving through embodied practice-based strategies. We're actually going to be linking her course to this lecture. So where you signed up, there will be a link to her course. And you're welcome to, of course, click in and learn more about it. We appreciate Dr. Barbier working with us. A small percentage of any sales generated are going to be shared with SoMeDocs to help us continue to run this networking and healthcare media ecosystem. And we are grateful for that. You can read the rest of her bio inside of her directory, because without further ado, I'm going to exit the stage. Dr. Barbier, good luck.
Thank you, Dr. Coriel. And yes, thank you for those who are joining this talk. I hope that you find it to be helpful and useful in whatever capacity you're attending this as, whether as a practitioner, a new or not new or aspiring parent, or even just a family member, human being, really. And as Dr. Coriel mentioned, I specialize in trauma, depression, and perinatal mental health. Today, what we'll mostly be looking at is emotional security and perinatal mental health through a slightly different lens. And that's going to be one that's more focused essentially on integration and the nervous system. I think Dr. Coriel highlighted most of the parts about me that I would highlight here. And I would say, of course, my disclosure is that while I'm trained across the gold standard treatments for trauma, that I'm probably biased just based on a recency effect by EMDR for depression, since I utilize EMDR the most in my practice, and New Harbinger just published my book earlier this year on it, which I've been working on the last year or so. And here are our objectives today. We're going to be covering this across, it'll be hopefully embedded across the different areas in the slides that we cover. But basically, I'd like you to understand how insight is different from integration when it comes to clinical outcomes for clients, especially those who you may be working with during the peri and postnatal periods. Introduce tools for promoting emotional regulation and secure attachment in the clients that you work with, and therefore in families and future generations, and see from that lens how what we're actually doing has a big prevention focused mission to it. So I'm going to start with the problem, which I'm going to actually frame in the lens of depression during the perinatal period. We actually know that it's an incredibly vulnerable period, and it's not just for mothers or birthing parents that it's more vulnerable for. As we know that perinatal depression is a frequent complication of childbearing, affecting at least 800,000 people a year in the US alone. And yet it's still pretty widely misunderstood in terms of how we conceptualize it and treat it. And when I'm saying perinatal depression here, by the way. This is talking about during pregnancy and or the postpartum period, which usually is studied for up to 12 months postpartum. And we're not talking here about the normal baby blues. Normal because at least 80% of people report experiencing the common baby blues in the few weeks following postpartum. We're talking about the symptoms listed in this picture here that are more pervasive and prevalent. So roughly 1 in 5 mothers from the latest research is showing that they experience perinatal or postpartum depression. And we're also seeing significant rates in fathers, with the rates more recently being 1 in 10, as well as non-birthing partners. For example, a recent study actually found that nearly 36% of sexual minority women screened positive for perinatal depression, and then over 60% of LGBTQ plus parents experience postpartum mental health complications, compared with about 34% of cisgender heterosexual parents. And importantly, many of these cases go underdiagnosed or undertreated, with Postpartum Support International, who I'm affiliated with, suggesting that only 25% of those who are impacted are actually identified and receiving the proper treatment for it. Pretty substantial numbers, and we'll talk kind of about the larger impact that has, not just on the individual who's in the caregiver, usually the primary caregiver role, but what impact that has on their child or children, their families, and for generations to come. And even though suicide is one of the leading causes of maternal death across the globe, I just want to emphasize again, this is not just a maternal issue. Any caregiving role can activate these sorts of patterns, which makes this relevant across genders and across family structures as well. And many, though, misperceive or that it's about something hormonal or situational or maybe even expected, given the intensity of this phase of life. And while those things are real, clinically, what I see over and over again is something deeper. I sit with parents, those who are often high functioning, insightful, and self-aware, who can tell me exactly why they feel the way they do, and then say, I still react the same way, I still shut down, I still feel overwhelmed in moments that shouldn't feel this hard. And at some point we ask, that invites us to ask, if insight were enough, wouldn't it have worked by now? Because again, this isn't just affecting mothers. We're seeing it across fathers, partners, caregivers, the non-birthing parents, in addition to the birthing parents, and across different family structures. And despite the increasing awareness, many of these individuals are still struggling quietly and often with a lot of shame as well. So this raises an important question, which is that if people understand their patterns, why do they still feel stuck? So here's our roadmap and how we'll approach this today. In general, I'm going to encourage today, instead of asking what's wrong with this person, this patient or client in front of you, we might ask what is being activated in this moment. I'll walk us through how I think about this, obviously having already started with discussing the problem, moving into that a little deeper, and then into the why, and then the gap between insight and change, and finally what actually helps shift these patterns, both in individuals and then across families and generations to come. So the goal is really to move from understanding to mechanism to application. So I've already reviewed some of the stats and prevalence of perinatal and postpartum depression across genders. And family structures, but I'll also highlight that without a doubt, the perinatal period is one of the most significant transitions in any person's life. And we're talking about the transition that happens not just physically, but certainly emotionally, psychologically, relationally. All of those things. Physically, obviously, we know there's a lot of things at play. Anybody's genetic predisposition, the sorts of sensitivities to hormonal changes, certainly the sleep disruption that is a combination of those factors, as well as how well the infant is sleeping. Psychologically, we're talking about the shifts in roles and identity, the identity shifts that happen, as well as, factors like temperament and attachment style, which we will get into shortly, and how those actually also interact with the social factors, in that these transitions and shifts often lead to subsequent shifts in the types of and quality of existing support systems. So changes are happening internally, but then also usually there are shifts happening socially as well in a sort of system in this particular context that overall increase people's vulnerabilities. In addition to just the reality that becoming a parent is a major nervous system shift. Increasing vulnerability in the sense of, we already talked about the certain statistics and prevalence of perinatal and postpartum depression across genders, and the reality that it reduces capacity, but especially when combined with these listed risk factors. So even people who were functioning well before might struggle during this time, but especially when someone has a prior history of depression. What we know about if the risk factor for developing perinatal or postpartum depression, if you've had a prior history of depression, it increases your risk by at least 50%. So we're talking about a pretty significant increased vulnerability, and in combination with other factors too, right? If you have a history of PMS or PMDD, that's and a sensitivity to those hormonal shifts or changes, that's definitely going to increase vulnerability for folks. Other types of things pertinent in psychological or social history, definitely the lack of support. And then what we don't necessarily think about when we think about lack of support is how that actually is informed by psychological factors like somebody's attachment. Usually the folks who have that lack of support, sure, might have these other social factors, but there might also be psychological reasons that impede them from actually being able to graciously ask for support and help, or to trust that help is even available. So a combination of those factors for sure increase vulnerability, and just because it's a huge nervous system overload reduces folks' capacity, which then has an indirect and direct effects, arguably, on their caregiving capacities. So, of course, kind of coming from that, the idea is that when we are more vulnerable, we go into crisis. We being just across humans, whether or not we are having children or not, when we experience an overload, or an overwhelm, our biological attachment system gets activated. And that attachment system basically triggers our experiences, usually born in the early learning, early memories from childhood, our formative years, about how we learned, how we could rely on ourselves, and especially whether or how we could depend or rely on others, especially a primary caregiver, to help us co-regulate, to help us feel safe, to help us get through crises. And so when you think about a huge stressor like bringing a new child into the home happening, it's activating this attachment system as well as the caregiving system simultaneously, which brings to mind a key idea. Becoming a parent doesn't just introduce a new relationship in the home, it actually activates and arguably reactivates the earliest ones. And to demonstrate this, just with a case example in my private practice, just the other week, a very intelligent, self-aware Lebanese American client of mine was noticing, she has a now almost 2-year-old, that when she was feeling more burnt out recently, amidst some work stressors, as well as she and her partner actually buying and moving into their new home, that her almost 2-year-old was having a crisis of her own. And in the middle of her tantrum, the daughter's tantrum, my client noticed feeling a nervous system overload or overwhelm associated with thoughts of how her daughter was being needy. And she quickly recognized that her thought was rather irrational, and was able to see that her toddler is simply having a need, not necessarily neediness. But that initial thought that she quickly was able to recognize, because we've been working together for a couple of years and increasing her capacity and regulation skills. Because she was able to quickly recognize that irrationality, she was able to identify kind of the source of that. And what was being reactivated was some of her own not fully resolved needs for attachment, where she had experienced in her earliest formative years parents who were going through pretty high conflict, leading to separation and subsequent divorce. And in the midst of all of that, there was maybe what one would label impaired caregiving, such that her, primary caregivers were not necessarily emotionally available, which translated to their lack of ability to be attuned to the amount of stress she was experiencing and the likely need for co-regulation that she was experiencing at the time. So in the midst of that significant emotional neglect, she noticed how that was actually getting activated while her daughter in the present day was having a tantrum. So that's just a demonstration of how being a parent isn't just introducing a new relationship, that our children and other people's children arguably are often revealing things within ourselves that we weren't even conscious of. So what we're seeing often is that perinatal distress is not just about the present moment, it's the reactivation of unresolved emotional patterns. And it reactivates those early relationships where we first learned what it means to be soothed, what it means to be ignored, what it means to be too much, or potentially not enough. And I'll kind of demonstrate another case example. I had another client of mine, a Cambodian American mother of a now 2.5-year-old son, is recognizing through her own parenting, which pretty drastically differs from that of her mother and father, how emotionally neglected she was. And some of this she's recognizing was perhaps culturally normative, but she's going through her own grieving process, which shapes the depression that she's been experiencing, while also still trying to maintain relationships with her parents, who she wants to have as active grandparents, of course, in her son's life. So there's a lot that we're navigating, and a lot that's driven by implicit memory and emotional learning that's getting reactivated. And that's kind of the lens I'm going to invite you to start to look at, especially depression during the perinatal and postnatal period, as seeing that the experiences of overwhelm, shutdown, and feelings of inadequacy can all be symptomatic of depression. And I'm going to take this on a slight detour, certainly connected as well, but I want to highlight to help you define and broaden and expand your definition of trauma, as well as notice the impact that trauma has, especially on those early formative years, and how that shapes attachment, which shapes some of these present day issues you may notice in your patients. Most of the time when we're talking about trauma, most people, at least based on the history of my training, when I trained in the DSM-4 revised going into DSM-5 years, we're taught that trauma are those obvious, overt events like abuse, assault, disasters, serious accidents or injuries, and combat exposure. I worked 6.5 years in the Veterans Health Administration system. But when we talk about trauma, we're not just talking about the big T traumas, which of course are the original criterion A. It's not necessarily just about what happens to a person, as in kind of the criterion A required for, in part for a PTSD diagnosis. We're talking also about how the nervous system experiences and stores overwhelming events. And traumatic experiences then, when we look at it in that broader way, are those that are overwhelming, invoke intense negative affect, and involve some degree of loss of control and or vulnerability. I think DSM-4 terms used to include in criterion A feelings of helplessness or terror or horror. And I invite you to continue to consider a child's experiences internally and how some of what they're exposed to may be interpreted in their nervous system with those levels of emotion. So the experience of trauma in that realm is actually subjective and developmentally bound. And that brings us to think about trauma as well as the little t traumas that might not be as overt or obvious, like the big T traumas are. Because when we think of trauma only as extreme events or big T traumas, we miss the quieter, more invisible experiences that shape how people relate to themselves and others. So these little T traumas or non-criterion A events include experiences that involve a combination of acts of commission, as in emotional abuse or chronic invalidation, and acts of omission, which are often more prevalent when the caregiver is impaired. And caregivers are impaired for a whole host of reasons, right? I mentioned earlier that Lebanese American client of mine had impaired caregivers and there was high conflict. So that client was also experiencing, witnessing likely domestic disputes and violence. But also, when you think about what plays into domestic violence and the potential for mother and or father having depression or other, mental illnesses of their own, that's what we mean by impaired. So the caregiver is often impaired due to mental health. It could be substance abuse. It could be the likely dual diagnoses because people often use and abuse substances because of mental health problems that are not optimally treated, which then lead to caregivers being misattuned and the child being emotionally neglected, and then likely carrying these experiences of helplessness, horror, and terror inside of them and not ever having it go about be repaired or resolved because of that misattunement. And usually this isn't intentional on a caregiver's part, but still has a significant impact on the child's development. Things like being consistently misunderstood, not having emotions mirrored, learning implicitly that their needs were too much or perhaps just not important and overlooked. And when we look at the studies that compare the impact of big T traumas and little t traumas, these studies show that victims of adverse life events across big T and little t traumas do not remember big T traumas as more traumatic than little t traumas. So that kind of brings home to point that these relational experiences, like emotional neglect or chronic invalidation, are often the least visible ones, but also often the most impactful, and the ones most overlooked. And then I included complex trauma in this slide just to an operational definition based on the research, but it basically describes a child's exposure to multiple traumatic events that are often of an invasive interpersonal nature and the wide-ranging long-term impact of this exposure. So usually complex trauma is referring to events that are severe and pervasive, such as abuse or profound neglect, which begin early in life and can disrupt many aspects of the child's development and the very formation of a self, then leading to putting a child at risk for developing what's called now complex PTSD. So, of course, they interfere with the child's ability to then form a secure attachment bond. And so that translates back to how, these early formative years that are so significant for forming a secure attachment can be left unresolved and then maybe lay dormant if it becomes the norm for a child, and then be reactivated in the context of a nervous system load, like introducing a new child into the home and thinking consciously, certainly subconsciously, about how you were parented or perhaps not parented as a child, and that becoming activated and prominent. So just to give you a brief overview of the stats and prevalence of trauma exposure, just to highlight how common trauma exposure it is. A national comorbidity study and its replication showed that approximately 75% of participants were reporting a lifetime exposure to one or more adversities. And unfortunately, the highest rates of exposure were identified in the youngest age group. And then we looked at a more diverse sample of urban impoverished African American communities, numbers about the same, a little slightly higher. And then looking at 2020 Child Protective Services reports, there were almost 4 million referrals, representing just over 7 million children. 20% of those cases were validated, and then we looked at the frequency. The majority of the reports there that were validated, the problem was neglect. And then another problem to a lesser degree being physical abuse, and then to a lesser degree sexual abuse. But neglect was reported the majority of times, which obviously points to an impaired caregiver, to likely multiple reasons, right? But that's just to highlight that when we're thinking about trauma exposure and what's happening and when, the numbers and research show how that tends to actually happen during the most formative years. So this graph just shows from ages 0 to 5, what's happening most often. 80% here is due to an impaired caregiver, closely followed at 78.4% by neglect. And then the things that often play into that are also being reported. So highest rates of exposure are in the youngest age group, and the often what's being reported the most is an impaired caregiver and associated neglect. And I'm assuming in this case, this is referring to physical neglect in addition, obviously, to emotional neglect. And I'd be remiss if I didn't also briefly mention the adverse childhood experiences study, which is one of the most influential ways that we've studied early trauma. And this is how they've categorized childhood trauma, basically. That's a questionnaire that includes 10 questions that fall into one of 3 categories, being abuse, neglect, or household dysfunction. The numbers show that 65% are going to list at least one adverse childhood experience. And when somebody lists one adverse childhood experience, there's an 80% likelihood they're going to report another. The questionnaire suggests that anything higher than a 3 is considered significant. I would argue that anything marked on there is likely significant because it's going to affect that child's learning experiences in some form or fashion. We're all exposed to experiences, and we learn from those experiences. Can be a good conversation starter too. So I recommend this questionnaire to help inform the lens through which you might be seeing somebody's present day distress. And basically, the evidence from the study demonstrates that adverse childhood experiences do indeed have negative neurodevelopmental influences that persist over the lifespan, particularly as it relates to an increased risk of depression in adulthood. Notice how in the household dysfunction, it carries many different things that can happen. Again, you want to think about the label of an impaired caregiver and how multiple pieces might interact here to help shape that there is an impaired caregiver, and obviously the higher the number of endorsed of these likely points to the higher the severity of impairment of the caregiver, which then translates, of course, to likely increased severity of their ability to be attuned to caring for a child, or anyone for that matter, themselves as well. So kind of just to highlight the point I just made, a strong dose response relationship, meaning the higher the number of ACEs a participant reported experiencing in childhood, both the greater the number and severity of mental health problems they reported experiencing in adulthood, especially the presence of a depressive episode in the past year or lifetime chronic depression, and a fourfold increase in the risk of depression. And then looking at another separate study that was done later, we tried to look at this from a different angle. Chronically depressed patients, looking at their trauma histories, over 75% were reporting childhood trauma histories. And of that sample, almost 40% of those had multiple childhood traumatization, to point to the fact there is a very strong link between adult depression and experiences of childhood trauma, which the kind of translating into the research on EMDR, more recent meta-analysis has shown that people with chronic and severe depression that is often treatment resistant is more responsive to EMDR. Why? Well, one theory could be that the idea that depression is actually rooted in unresolved early trauma, and the fact that EMDR is the only therapy that focuses on trauma, when we look at depression treatments, that might be why it's having a greater impact in comparison to other therapies for chronic depression. And to this point, we looked at a little bit more of the ACE study findings were replicated in a more diverse sample, just to prove the point that this isn't just limited to a European American Caucasian sample. And they also looked at the types of adverse childhood experiences to see which of the ones that were most strongly linked to depression. And what was found was emotional, physical, or sexual abuse, emotional neglect, mother being treated violently, or living with someone who was essentially impaired, depressed, mentally ill, or attempted suicide. And then in another study, it was highlighted that in a less diverse sample, though, that emotional abuse and neglect were the types of childhood traumas most strongly linked to depression in adulthood, followed closely, though, by other kinds of childhood trauma, including sexual abuse, domestic violence, which means witnessing domestic violence, and physical abuse. So all of this is basically just, again, highlighting that we may benefit from conceptualizing depression through that trauma-informed lens, especially when it's severe chronic depression, specifically for assessing for those little t traumas more that involve emotional neglect and abuse and validation, and point to the household dysfunction that might have amplified an impaired caregiver that amplified then the misattunement and associated emotional neglect and abuse. And then this graph is just to point to the strong dose response relationship between the higher the ACEs, the higher the risk for depression, and then also the sorts of lifestyle behaviors that might accompany depression, like smoking, drug use, and attempted suicide, alcoholism as well. So these early experiences, basically in a nutshell, shape our patterns, which affects how we respond emotionally and relationally. Those patterns become automatic, ingrained, embodied, and usually outside of conscious awareness. And these experiences don't just shape our beliefs, they shape how the nervous system learns to respond and beliefs are born in the nervous system. What makes a belief is not just an intellectual understanding, it's an embodied emotional embodiment of that belief that then manifests in all sorts of ways of behaving and relating. And these responses aren't chosen, right? The kind of point to drive home here are they are learned adaptations. And so how I'm often conceptualizing somebody's present day behaviors that sure may no longer be adaptive is I'm trying to understand how were they actually once adaptive? Because when we can view it through that lens, it's showing unconditional positive regard, which is one of the reparenting strategies I'm going to introduce later, and helping someone normalize and turn toward their experience with compassion and curiosity, which actually helps regulate their nervous system. But where an important distinction comes in and where the gap lies is in cognitive versus emotional insight. Understanding something cognitively is very different from experiencing it differently. And cognitive insight is the understanding why, but emotional insight is actually experiencing something different on that feeling level. And in order for change to actually be sustainable, we need both, especially the emotional insight. Many people who say they have insight are often usually referring to this intellectual understanding rather than this emotional insight. And what we know is through processing therapies between cognitive processing therapy and EMDR, for instance, is that it often takes our emotional brain a bit longer to catch up to the logical intellectual brain. And it's because of the need for experiences. We need, and that's going to have inform the reparenting work and strategies. So if the patterns were learned through experiences, they don't just change because we understand them on an intellectual level. They change when we have a different experience. So it's not just about telling yourself to think differently or understanding the roots on an intellectual level. It's thinking about what actually creates change. And I invite you to think about this in the lens of when, you were going through school to become a practitioner, the difference between knowledge and the application of that knowledge. You likely learned quickly that they're two completely different things, and that knowing one thing on an intellectual level, sure, is information that you've learned, but actually applying that knowledge requires a lot of experience in order to build your confidence, in order to build your competence, in order for it to then become second nature to you. You didn't just become an experienced practitioner overnight. It required many, many, many hours and years, arguably, to gain that competence. And so this is kind of working in that same way. The answer comes down to experience. So if nervous system patterns became shaped by experiences in childhood, then that means that they also have to be shifted through experience, which is where the emotional insight then catches up to cognitive insight, which together can then help promote integration. So again, from this lens, depression often isn't just a cognitive problem. It's a cognitive problem in the sense that it's coming from a learned nervous system state, a kind of shutdown, a reduction in capacity to feel, to stay present, to respond flexibly. And when you combine that with the demands of early parenting, it obviously makes sense that people feel overwhelmed. So the question becomes not how do we help people think differently, but how do we help people experience themselves differently? And this is where emotional security comes in. Not as a concept, again, but as essentially a lived experience, because it's through experience that we start to embody things little by little. Emotional security is a felt sense of safety within oneself, I think, first and foremost, and therefore in relationships as well. Learning to experience themselves differently, which of course, though, in the context of a practitioner-patient relationship, gets translated to and that models that for them, often arguably as the secure base that they perhaps hadn't had before, which speaks to the importance of us doing our own inner work to be able to embody that secure base, which then helps them experience themselves differently. And then they can start to do that outside of our actual face-to-face interactions as well. And just as we learned through the ACEs research that those relational little t traumas like caregiver inconsistency and misattunement and the associated chronic stress can disrupt the development of emotional security. Emotional security is going to develop through relatively consistent, because we're not perfect, attunement, repair, and predictability. And to that, I will say just this morning during an EMDR session with a client of mine who's a second generation Cantonese American cisgender female client, after a handful of sessions with us reprocessing the same target memory, she was just this morning starting to more deeply attune to her younger self in this target memory, who is, I believe, somewhere around 4, and was more attuned to her younger self's lack of feelings of safety and the associated unmet needs there. And so that naturally allowed her to attune and then to imagine herself actually stepping in and providing that younger version of herself what she needed. And in turn, this actually created a felt sense of safety in her body in the present, as in this morning's session that we had. She was creating a more integrated sense of safety that she's feeling now. And because she's attuning to parts of her that were not consistently attuned to, and not because of intentionality, right? Where she was just simply recognizing and attending to an unmet need in a way that actually deepened security and helped her feel more safe and free in her body, which is something we've been working on over time. But it takes time. And why does it felt sense that I'm safe, my emotions make sense, and I can move through distress and come back matter? Well, for a lot of reasons, right? But in summary, it's because it supports regulation, attachment, and resilience. And again, importantly, it's not something that we teach. It's something that we learn through experiences, just like the client I referenced. That same client also noticed that she could access these protective feelings toward her younger self because of experience. She had had a recent experience where she noticed a protective and compassionate side of herself coming out when she was observing a young child who just happened to look similar to her younger self. So again, it's pointing to how new experiences facilitate the kind of learning that's needed to shift inner experiences and create greater feelings of inner security in turn. So in a nutshell, change happens through new experiences and not just the insight. And arguably that emotional insight often needs the experiences to be felt and acknowledged. And I'll end on the important note of you cannot give others, especially your children, the emotional security you haven't yet truly given yourself, especially since children often learn more from our nervous system regulation rather than what we're actually saying out loud. And this is where the concept of reparenting comes in. Providing internally and relationally what wasn't consistently available earlier on in life, especially going back to the earlier recognition that emotional neglect and abuse, those relational little t traumas, are often the types of adverse childhood experiences most strongly linked to adult depression, and likely the little t traumas most likely getting activated in the context of perinatal and postpartum depression when somebody is going through becoming a parent and then subconsciously being reminded of the ways that they were and perhaps were not parented. So again, the emotional insight is going to be attained through this process of helping parents experience something different internally and not just understand something different on an informational, intellectual level. Because, as I mentioned earlier, when reviewing the nervous system lens of depression, if those early or original patterns were learned through experience, then new desired patterns have to also then be learned through experience. There's not really any shortcuts if you're looking for lasting, sustainable change, which most people usually are, right? And again, kind of using the analogy for us as practitioners, knowing material intellectually is one thing, whereas the application and competency in application of that material is a completely different ballgame, requiring both breadth and depth of experiences in order to be embodied. But then once it is embodied, it's like your instinct and intuition, and it just rolls off of your tongue. And I'll highlight that reparenting is not about fixing the past, especially using the word fix for somebody who's depressed would potentially reinforce any core beliefs they might have about themselves as needing to be fixed because they're not good enough, they're flawed, they're defective in some way. So it's more about, and my book talks about the solution being one of acceptance, not of what happened on the outside, but more of the acceptance of the inner world, which is what creates more flexibility, expands somebody's capacity, and of course increases self-compassion, which increases self-efficacy and feelings of confidence to navigate and security to navigate challenges in the world. So reparenting is not about fixing the past, but it is about creating new experiences in the present that the nervous system can learn from. So what we're really working to change here is the capacity to feel, to stay present, to tolerate distress, and to experience and relate to themselves differently over time. And when we look at the processes in reparenting that actually create that internal shift, it tends to come down to a few core mechanisms here. Safety, the repetition that's needed for learning, especially to embed in the implicit memory, attunement, and integration. And this is not a linear journey by any means either. So the safety, of course, is alluding to the fact that the nervous system has to experience enough safety to begin reprocessing, which for clients who have early, chronic, potentially complex trauma means in the context of a relationship with the practitioner may require repeated interactions where they learn that you are safe. In addition to other skills, which then translates to the parenting context as well. But repetition, of course, it's not a one-time insight. It's something that has to happen over and over again. That's how the learning and embedding new emotional experiences into implicit memory works. Attunement being seen, understood, and responded to accurately, and ultimately integration, where new experiences begin to reorganize how the person responds both emotionally and relationally. So this is less about information and more about pattern interruption and pattern replacement over time. These show up in several different reparenting strategies, such as safety, attunement, consistency, and unconditional regard. We're modeling this, of course, in our relationship as an ultimate secure base for the client or parent, which they then learn to internalize. That's how the attachment system works, right? We just because our attachment figure isn't physically present, it doesn't mean that we don't have their felt sense in our nervous system. So we're trying to have through the new experiences through the actual client practitioner relationship, have them internalize that secure attachment, which then translates to how they relate to themselves outside of session, and therefore how they relate to others around them, especially those for whom they're caregiving. So the first strategy is building safety, and this is often much slower and more subtle than we expect. like the client I'd referenced, it can look like slowing the pace of therapy, helping clients notice what's happening in their body through building the skill of mindful or non-judgmental awareness, creating predictability in the session over time, because without safety, the nervous system stays in protection, and when it's in protection, it can't fully process. These are used interchangeably and not necessarily one by one. Again, it's the idea that they're embodied. So the second is attunement, which is where we're helping clients put language to their emotional experience and also validating that experience. As I said a little bit earlier, I think I mentioned the fact that we're trying to help them see and understand the roots of their depression in such a way that they see that their current patterns as adaptive, so that they're not so shameful and shaming on their behaviors or patterns now, which puts them in a vicious cycle or trap of staying kind of in that negative state that's perhaps no longer helpful, but perhaps was once protective in some form or format. And many patients with depression who have histories of emotional neglect never had their internal world accurately mirrored. So you're providing a corrective experience by actually attuning to and helping bring that out. And you're also probably helping meet unmet needs for co-regulation. Children very much depend on their caregivers for co-regulation because they literally don't know how to regulate their experience. It requires skill, which requires guidance, which requires attunement. The third is consistency and boundaries, which is where we're creating structure and reliability, following through, being predictable, maintaining appropriate limits. These things might seem basic, especially for those who are relatively secure, but they're actually deeply regulating, especially for clients who grew up in environments that were inconsistent or chaotic. And then the fourth is unconditional positive regard, which I'd mentioned before, which is where we're actively working against the experiences of toxic shame, helping clients develop a different internal voice, ones that's more compassionate, more flexible, less punitive, because for many clients with depression, the internal environment is one of constant criticism. We're trying to help combat that. We're also trying to befriend the critical side to see what its intention is too, to remember that that's a part of them that, again, likely developed as an adaptation. So when we put this all together, reparenting doesn't look like a single intervention. It shows up in how a parent learns to show up for themselves, first and foremost, and therefore for others, especially the children that they're raising, how they respond to rupture, hopefully with attuning to them occurring in the first place, and then taking the initiative to go about acknowledging and repairing them. So that it requires a lot of skill sets just in that alone, being attuned, being able to be emotionally present, and then with that being also able to model vulnerability in the sense that it models a healthy, secure relationship where two people are taking responsibility for their part. And that is especially important because we're not expected to be perfect. And so what that means is we have to acknowledge our imperfections by being willing to self-reflect and being willing to be vulnerable to verbally acknowledge fault where it's due, but also match our verbal acknowledgement with our behaviors as well, right? Which is why guilt exists in a healthy way. Guilt is healthy in that it acknowledges that we're imperfect and we make mistakes that violate our code of being, and then motivate us into course correcting, both through verbal, emotional acknowledgements and through behavior and action as well. And then, right, emotional regulation speaks to how we, as parents, hold a space for our own emotional experiences. The more we can hold a space for our own discomfort, the greater we expand our capacity and our ability to therefore hold a similar space for children's emotional experiences, of which there will be a lot. And we can't give what we haven't experienced, but we can learn it. through new experiences. And again, that's where we come in as practitioners, helping clients build that capacity through our own embodiment and manifestation of social emotional security, acting as models and secure attachment figures for them to hopefully also internalize and then give. And this expanding of our capacity becomes especially important in parenting because children don't learn regulation from what we tell them, as I alluded to earlier. They learn it through the parent's nervous system. So they learn it from what they experience from and with us, from our tone, from our presence or lack thereof, and especially our ability to stay present emotionally, especially during distress. They learn what emotions mean and whether they're safe. And as I've been emphasizing, that regulation is learned through experience for parents, the same is true for children. Experiences is where true learning is going to happen versus just instruction. And this is where the conversation expands, because this isn't just about treating depression, it's about preventing the transmission of these patterns across generations. When we support a parent's nervous system, we're actively shaping a child's emotional world. And in turn, we're ultimately helping create emotionally secure generations. The perinatal period obviously offers both high vulnerability and high potential for change. So our role is to normalize, support regulation, and encourage attunement. And these are foundational shifts, but they take practice, repetition, and support to fully integrate. So just to bring this all together, we've talked about how perinatal depression is common and often driven by deeper patterns rooted in trauma, especially early relational attachment trauma that's been left unrepaired and unresolved. Patterns in how people relate to themselves and how they respond emotionally, and what their nervous system has learned to expect and tolerate. We also looked at the gap that many of us see in practice, where insight alone, even really meaningful insight, isn't enough to shift those patterns. And then from there, we moved into a different way of thinking about change, not just at the level of thoughts, but at the level of the nervous system. Because ultimately, sustainable change tends to happen when we're able to increase regulation, expand capacity, and support new experiences, not just new understanding. That's what builds emotional security that lasts, not just a lifetime, but arguably an entire lineage ahead. So if we translate this into clinical practice, there are a few core takeaways. First, assessing beyond symptoms. We're paying attention to regulation, to capacity, to how clients are actually experiencing their internal world, not just what they're reporting cognitively on the surface. And we're doing that by working with the system, understanding maybe where present day symptoms are rooted in unresolved attachment systems getting reactivated, especially most vulnerably so during the perinatal period. And rather than only targeting thoughts or behaviors, we're also supporting the nervous system, helping parents stay with experience, process emotion, and build tolerance over time through experiences so that they can embody this for their children. And then third, we're using relationships intentionally, we being the therapist-client relationship, which then translates to the client's relationship with everyone else in their lives, especially their partner if they have one, and children. Recognizing that how we show up, our attunement, our pacing, our consistency is not just supportive, it's part of the intervention itself. So to bring this all together, perinatal depression is not just about the present moment. It's about the reactivation of earlier patterns. Insight alone isn't enough to shift those patterns, but experience can. And when we start working at the level of the nervous system, that is when we support regulation, safety, and emotional capacity, that's where we begin to see more sustainable change. And as Dr. Coriel mentioned at the beginning, if you're interested in going deeper into how to apply this in a structured way, I do have a reparenting course where we build this out step by step. But even just beginning to shift your lens in this way can change how you approach this work. And ultimately, when we support the parent's nervous system, we shape the child's emotional world. So, thank you.
Thank you so much, Dr. Barbera. I'm just going to add myself here to the front. If you want to stop sharing, you can, but I'm also going
Okay.
to share my screen. You can send Dr. Barbir an inquiry. So first of all, you could just easily just search and things will come up. But a more organized way is that you can find experts and you can actually go to where you're looking for an expert. So in her case, she would be under therapists. It's a new directory that we've built. There is her profile. You could also, of course, use the filters on the side, but you can open up her profile and then send her an inquiry right here. You could jump to that inquiry and you can fill it in and it'll land directly in her email. But you can also follow her on social media. You can see some of the other things that she's built. She has a speaker page and she's got a YouTube page. And she's got lots of different things, and you can, of course, interact with her profile right here. She's also in our WhatsApp community, so we invite you to join us. Of course, you can send her an inquiry, but let her know just how great her lecture actually was, especially because we have made it free. So thank you so much, Dr. Barbir.
Of course, yeah. Thank you again for having me.